All right, welcome. If you got an OSCE on headache syndromes just around the corner, then you are in exactly the right place. This is your high-yield review. We are going to walk through the exact clinical reasoning you need to absolutely nail that headache station.
So here's our game plan. First, we'll set the scene and talk about the OSCE challenge itself. Then, I'm going to give you a super powerful clinical framework to follow. After that, we'll apply it directly to a patient case, from history all the way to the management plan. And we'll wrap it all up with the absolute key points your examiner is listening for.
Okay, I want you to picture this. You're standing outside that exam room door. You've got maybe 2 minutes to read the prompt, your heart's probably thumping a little bit, and you know the patient is just waiting on the other side. This is that high-pressure world we're getting you ready for.
The prompt on the door says, a 35-year-old male presents with a severe, recurring headache. So, what's your immediate thought process? What is your very first move? The trick here isn't to know the answer right away. It's to not panic and to have a system you can rely on.
And this is that system. Think of it as your protocol, your roadmap. It's designed to guide you from the second you walk in that door all the way through to presenting a solid management plan. This is your essential toolkit for success.
And here it is, a simple 6-step framework. You start with history, move to the exam, actively look for red flags, then form your diagnosis, create a management plan, and finish with patient education. It's logical, it's thorough, and trust me, it's exactly what your examiner wants to see. So let's put it into action with our patient.
We're diving into step 1, taking a killer history. This is where you're going to get like 80% of the information you need to crack the case. It's all about asking the right questions. Let's go. So you walk in, you introduce yourself, and your first line of questioning has got to be all about characterizing that pain. You're going to ask something like, can you tell me a bit more about this headache? Where exactly is the pain, and what does it actually feel like?
And here's what he tells you. The pain is excruciatingly severe. It feels like a stabbing sensation, and it's always on one side, right behind his eye. Now, you got to listen closely to those words: excruciating, unilateral orbital, stabbing. These aren't just descriptions, they are huge diagnostic clues.
Okay, great start. Your very next question has to dig into the associated symptoms. This is what really helps you tell the major headache syndromes apart. You ask, when you get these headaches, does anything else happen at the same time?
And boom, here's the rest of the puzzle. He says his eye on that same side starts tearing up and his nose gets all stuffy, but only on that side. The attacks are hitting him 2 or 3 times a day, and this whole episode has been going on for the last 3 weeks. These symptoms, the same-sided autonomic features, are what we call pathognomonic. They're basically a giant flashing sign pointing to one specific diagnosis.
All right, let's shift gears to the next phase of the encounter. We're talking about the physical examination, and maybe most importantly, the hunt for any red flags. This is all about what you can see and making sure the patient is safe.
Now, the patient also tells you that during one of these attacks, he literally can't sit still. He feels super restless, agitated, and has to pace around the room. This is a classic differentiating sign. It's the polar opposite of a typical migraine patient, right? They just want to curl up and lie still in a dark, quiet room.
So you go ahead and perform a full neurological exam. You check the cranial nerves, motor function, sensation, reflexes, the whole shebang. And what do you find? Absolutely nothing. It's completely normal. This is a massive finding because it pushes you away from a scary secondary cause and points you right towards a primary headache disorder. Now, you quickly run through your red flag checklist in your head, that Snoop mnemonic. Are there systemic symptoms, like fever? Nope. Any new neurological deficits? No. Was the onset sudden, like a thunderclap? He didn't say that. And has the pattern changed? No, it's been stable for 3 weeks. So your conclusion is crystal clear. There are no red flags present, which makes a dangerous secondary cause super unlikely.
Okay, you've done the hard work. You've gathered all your data from the history and the exam. Now it's time to put all those pieces together, come up with a clear diagnosis, and lay out a safe and effective management plan.
So the diagnosis is cluster headache. But in an OSCE, you can't just stop there. You have to be able to explain the why, the mechanism. It's all driven by hypothalamic dysregulation, which explains that cyclical, clockwork-like pattern, and it's combined with a trigeminal autonomic reflex, which is what causes that awful one-sided pain and all those associated tearing and nasal symptoms.
For managing an acute attack, your #1 first-line therapy is high-flow oxygen. And you have to be specific with the prescription. It's 100% oxygen at 12 to 15 liters per minute, delivered through a non-rebreather mask for about 15 to 20 minutes. It's fast, it's safe, and it works. Your key alternative, if oxygen isn't available or effective, is subcutaneous sumatriptan.
Now for prevention, to stop this whole cluster of attacks in its tracks, the first-line medication is verapamil. But, and this is a crucial safety point, you have to mention that you'll monitor the ECG for any cardiac side effects like heart block. Finally, patient education is key. You've got to counsel them on avoiding known triggers like alcohol and explain the episodic nature of their condition so they know what to expect.
Now let's boil all of this down into the absolute key points that the examiner is just waiting for you to say. These are the high-yield takeaways you need to have locked and loaded for exam day.
First, and you should probably commit this to memory, primary headache diagnosis is clinical, red flags guide investigations. This sentence shows the examiner you know that your hands-on clinical skills are what matter most here, not just ordering a bunch of tests. Second, mechanism-based differentiation is key. You have to know the underlying science. That means knowing migraine is trigeminovascular. Tension-type headache is about muscle tension, and cluster headache, as we saw, is hypothalamic plus a trigeminal autonomic reflex.
Third key point, management is multi-pronged. You should always communicate that your plan has 3 parts: acute therapy for the attack right now, prophylactic therapy to prevent future attacks, and of course, lifestyle modifications to help manage triggers.
And fourth, you have to know how you're being graded. The scoring sheet for this station will absolutely emphasize these 4 things: your structured approach to the history, your clear identification of red flags, your ability to explain the underlying mechanism, and a solid evidence-based rationale for your treatment choices.
And here is one final thought to carry with you into your exam. Be ready for the follow-up questions. They are absolutely going to ask you about drug mechanisms, why you chose one therapy over another, what the contraindications are, and the nitty-gritty pathophysiological differences between the syndromes. So the real question is, are you ready? After this review, I think you are.